Well, good afternoon, everyone, and welcome to the fourth session in the European Observatory Venice Summer School, this year not being held in Venice, but being held virtually. And I'd like to welcome everybody to our online presentation. So, this session is about the best person or machine for the job. Everything has changed this year. The way we deliver health services has changed beyond all recognition. Health services have come under incredible pressure. There has been massive increases in some places in the numbers of patients suffering from COVID, and at the same time, health facilities have had reductions in staff from illness and, tragically in some cases, from the premature death of some of the people who have been contributing so heroically on the front line of healthcare. The only way that health services in some places, the countries that have been affected most, have been able to cope is by everyone stepping up and going beyond their comfort zones, doing things that they might never have imagined before. Many of the rules about who can do what have been torn up, and we are now finding imaginative solutions to dealing with the challenges that have been thrown up by the crisis. People talk about the new normal. We will not go back to doing things the way we always have done. We'll have more webinars like this instead of face-to-face conferences, for example. But we're also going to see big changes in how we deliver healthcare, and that will involve people doing things they didn't do before. They will involve looking at new ways of doing things. So it's particularly timely then to look at the issue of task shifting. I'm really pleased to be able to invite two outstanding speakers to talk to us today, to share the information they have gathered in two major exercises over the past year. The first is Maier Schalkwyk from the London School of Hygiene and Tropical Medicine, and she will be talking about work that was done that she supported for the European Commission's expert panel on investing in health, a major report on task shifting, which you can download from the expert panel's website. And the second speaker is Claudia Maier from the Technical University in Berlin, who has been doing a great deal of work on the nursing workforce over many years and is responsible for a forthcoming publication on task shifting, which will be coming out from the European Observatory. Now, the format is that both of them will present what they've been doing, and then we'll move into a question and answer session. And the Q&A will be chaired by my colleague, Dimitra Panteli from the Technical University Berlin and from the European Observatory. And at this stage, I'm going to pass over to Dimi to explain how she will be doing that and how you can interact with the process. Dimi, over to you.
Thank you very much, Martin. Hello, everybody, also from me, and welcome back, or welcome if you're here for the first time today. The Q&A sessions have been developed and have developed over the past few days a certain way that has worked out really well. So I think we will stick to that plan today. For those of you who haven't done this before, just a quick introduction. And for those of you who have been here now a couple of times, a quick reminder. If you hover your mouse to the bottom of the screen, you see two different ways to get in touch with the chair and with me. There is the Q&A with a double bubble at the bottom of the screen and the chat function, so two separate functions. And the chat function you can use, as Zaza has already used it, to say hi or to provide a general comment or a general question that you have. The Q&A is for specific questions for the speakers. So if you have, during the talks of Claudia and May, specific questions or general questions on the topic that you want to ask, please use the Q&A function. So click on the Q&A sign at the bottom of the screen and type your question there for everyone to see. One important feature of the Q&A section function here is that you can type your own question, but you can also, like, as we do on social media, the questions that are already there. And what we will do at the end, after the two presentations, is that I will make sure to, first of all, pass on all the questions with the highest numbers of likes, and also make sure that we don't forget anyone, and that we group also the questions in a way that makes sense for our speakers. So our request for you is that if you have a question during the talks, you type it in the Q&A function. You might want to add the slide number. So the slides that you will see have numbers at the bottom. So you might want to add the slide number to make it easier for us to identify what exactly it is that you want to clarify. Or you might want to add who the question is for, but you can also just ask more generally, and then I'll make sure to pass on the questions as best as we possibly can from the overview here in the Q&A. So much from my side. So remember, Q&A for questions on the topic, chat function for general issues, comments that you might have. You can like other participants' questions, you can type in your own. And at the end, after May and Claudia have presented, so we won't be interrupting them, we'll get to all of your questions and make best use of time to get as much feedback as possible. Back to you, Martin. Thank you very much.
Dimi, thank you very much indeed. And with, I will now just move straight on to our first speaker, May van Schalkwyk. I've already introduced her, and she's working with me at the London School of Hygiene and Tropical Medicine, and made a major contribution to our expert panel report on task shifting. May, over to you.
Well, hi everyone, and thank you so much for joining. It's a pleasure to be here today. So what I wanted to do, so we're going to be talking about task shifting, but I think it's very helpful to just step back and think about, well, what are we actually trying to do here? And as Martin was saying, you know, in the context of COVID, we're thinking about, you know, delivering high quality, fair, equitable health systems. And as COVID shows, we need health systems that adapt and are resilient to the need that evolves from our patient population. And a big part of this, and this is a huge challenge, obviously meeting ever evolving need, and a major pillar to health systems is the workforce and the distribution of different skills and different types of health professionals within that workforce. And that's a phenomenal challenge as well. And it's something that health systems all over the world are grappling with. And so what I wanted to do here was just use these slides as the type of analogy to talk about that skills mix in your health workforce. And what you can do, if it's not, you know, thought through carefully and without evidence-based, is you end up with this rather rigid, unhelpful mix, or this knot of skills among different types of health professionals that isn't necessarily flexible, and doesn't necessarily meet patient need. And then what I wanted to represent here was that if you get that mix right, you can really, really strengthen your health system. You can meet ever-evolving need, and you can deliver high quality and equitable care. Of course, there are other considerations as well, but that skills mix amongst your health workforce and the type of health professionals you have is absolutely key. And this is why we're talking about task shifting, which is about the movement of different tasks, thinking about how many types of health professionals you have and who's doing what and why. And unfortunately, over time, we've noticed that task shifting has become it can become very simplified in its definition and the way people are conceptualizing it. And what tends to happen is people see it as a way of saving money within the health system. So you take basically health professionals who are seen as higher skilled and more expensive, and you say, well, let's just get less skilled apparently and less expensive health professionals to do that task. This definition isn't helpful and doesn't really help us conceptualize how task shifting can be used as a way to deliver high quality care that meets ever evolving need. So there's this need to kind of step back and say, how can we better think about task shifting? How can we understand from the evidence how we can use it to really meet patient need and build better health systems? And a part of that consideration is also understanding it's going to be very much about balance as well, and how you incentivize or build the right balance. So you want to make sure that you're not getting a certain type of health system that's just driven by the latest fad, so that everyone wants to become an ophthalmologist or everyone just wants to become a physiotherapist because that's a better training pathway. You want to be thinking about how you get the right mix at the right time, the right people doing the right job, and that's flexible and can meet ever-changing need. And also it is often with a lot of things in public health is stepping back and also challenging existing and historical ways of doing things, certain hierarchies that have become entrenched over time and aren't necessarily based on facts around who can do what well. And we particularly see this often in health systems, in medical professions, where these ways of doing things just aren't being challenged regularly enough, and we're not asking what the evidence is behind the way we're doing things. So actually, in recognising the need to kind of broaden our thinking around task shifting and support nation states in thinking about how they can use it to strengthen their health system, not necessarily just as some sort of cost-saving exercise, they commissioned the expert panel on expert ways of investing in health, as Martin mentioned, to undertake a report on task shifting, looking across the evidence, what works where, what can be shifted between who, what new skills can other types of health professionals take on, and what recommendations we can give for countries to think about how to use it well in their health systems. So we developed this conceptual framework building upon some previous work done by Sibbald et al. And it's a way of thinking through task shifting, what to shift between who, what types of health professionals and other people in the health service, and for example, patients and carers, as well as machines, so how to use technology to enhance roles or take on tasks themselves. So who are we shifting between, but also what are there different types of task shifting, and are there useful ways of thinking about them? And we found in our analysis of the research that actually we identified three broad, what we kind of called categories or types of task shifting, or ways in which you can change people's roles within the health system. So the first was substitution and delegation, and that's simply a shift of the responsibility of a task or a role from one type of health professional to another. So doctors to nurses, or doctors to pharmacists, or nurses to doctors, healthcare assistants, for example, but also to patients and carers as well. And then delegation is more of a kind of recognition that it might be kind of going down what the kind of arbitrary skills hierarchy. And then you've got enhancement, which is taking someone's role and broadening the depth and nature of that role. So giving them more skills and more responsibility, and furthering their competencies and things like that. And then of course there's innovation. So this is new models of care, new ways of running different teams within the hospital, and also the introduction of different types of people into the healthcare system. So seeing patients more as their own carers, using it in innovation and different types of technologies. So we're going to go through all the evidence behind this that we've identified. But I just wanted to say this is a very high level, just touching on a lot of this. And as Martin said, we very much recommend going back to the report and going through it, and there's some really important details there that I won't be able to go through today. And it's just to say that wherever possible, we've drawn from systematic reviews for the evidence that we're going to be talking about. And just to remember that a lot of all the evidence is obviously before the pandemic, and the pandemic, as Martin was saying, has really will have brought in a huge array of different ways in which tasks have been shifted. And so obviously there will be a wave of evidence that will come after this, and the way we've gone to telemedicine and other considerations like that. So I think it's just really important to keep that in the back of your mind, and realizing the evidence base will change very rapidly. And what I wanted to kind of get to you with this nice scene is one, you've probably been missing things like this locked in your homes, but also just to think about how the context will really matter for research like this. And the reason to really send this message is to say that this has implications for the transferability of the findings of these particular research. And whenever you're studying humans and doing different things, it's very specific to the context. And of course, we must challenge the assumption that what works in one place will not necessarily just work in another. And that's important when thinking about implementing based on the evidence that we've got. So the first type of task shifting, drawing on that concept of substitution, is the tasks shifting from doctors to nurses. And there's actually a very large body of evidence on this type of task shifting. But it's important to remember again that this is in a very limited kind of setting. And so that comes back to what I was talking about with the transferability of findings. And again, what we see across the board actually with all the evidence is that it varies greatly in the methods used and the types of tasks being shifted between different health professionals and the outcomes being measured. And this is really important because obviously with health systems research, we really want to be understanding how it translates into things like patient benefit, or strengthening the health system, or making it more cost effective or more useful way of resources. So it's very difficult to compare studies, and it's really thinking about what are the outcome measures you're interested in strengthening the health system. And so we do see that there's actually some good evidence that nurse-led care leads to as good as, if not superior, outcomes in comparison to physician-led care. But again, it's important to remember that that's with the appropriate training. And that's something we'll come back to a bit later, is thinking about what's actually needed to make sure it works well. And this is particularly in relation to certain tasks. So it's always thinking about the specific task that the research was looking at. So for example, post-operative assessment, care of obstructive sleep apnea and weaning from ventilation. There was evidence of as good as or superior outcomes. And another review found that nurse-led care led to no appreciable difference, but again, the context was important. So things like chronic management of chronic health, chronic conditions, in relation to things like health outcomes, and importantly for a health system, resource utilization and cost. But as I was coming back to what I was saying earlier with considerations around cost, is that specifically when we're talking about kind of moving away from doctor-led care, is often this is seen as a cost saving, but actually what you might end up doing is just meeting unmet need. Or generating new demand. And so these are really important considerations when you're thinking about using limited resources. And then there's the enhancement of the role of nurses. And this is seen quite commonly across the world in lots of health systems, and continues to happen as the role of nurses is broadened and they take on a lot more skills. And again, we have mixed findings, and it's very context specific. And what's interesting is that, so there was a Cochrane review showing that there's no clear evidence of an association between certain nurse staffing models, for example, and certain outcomes, so such as mortality, emergency department attendances, or readmissions. But there is some evidence of a reduction in length of stay and incident to pressure ulcers. And the reason that's really important is those are the kind of outcomes that really matter to patients and their families, and also the kind of economic activity, getting back out into society. So these are important, and these are the types of outcomes that will matter. We also found that there were mixed findings. So again, not a very clear picture here on nurse specialists or nurse-led care in the settings of things like chronic renal disease, cancer, and palliative care. And again, different outcome measures are used, so it's hard to compare again. And then we found varying results for other enhanced roles. And importantly, when we're thinking about how to use resources effectively to get the best outcomes, we found that the economic analyses for things like clinical nurse specialists is generally very poor. So again, that we need more research there so that we can be thinking about how to use the resources we have at hand, which are often really limited, to maximize the results. The next one is thinking about enhancing the role of pharmacists. And this is particularly an important area because the role of pharmacists are changing all the time. And it's really important to understand that that's reflecting, for example, changes in the way we make and produce medicines as well. But we also know that there's evidence showing that this enhanced role actually comes with a beneficial outcome. What we know is that compared to physicians, for example, there's at least as good outcome as when physicians deliver it. So when we see the medicines management by pharmacists, we get as good an outcome as if they were as if it was being conducted by physicians, and particularly in the context of a rushed consultation, and particularly in relation to pediatric care. What we have is we do see that there are improved outcomes, for example, understanding medications, adherence, satisfaction, and disease outcomes, which is really important. Sorry. Okay, and then hand in hand with that, we also have then the substitution of prescribing. So that was medicines management in relation to the enhanced role of physicians. But what we also then have is different health professionals taking on prescribing. And one review found that non-medical prescribers are at least as effective as doctors prescribing. Again, this is specific to certain settings, so that's a really important consideration, but also thinking about the level of autonomy in any particular study given to those non-doctor prescribers. But generally in this evidence, we found that there was a high level of autonomy given. And then moving on to the final type of task shifting, this is in relation to innovation. So different types of models of care and other forms of task shifting. And we'll go through those one by one. But again, just to emphasize, this is very high level and I'm just touching on some of the evidence. So please do go and read further behind it to get more of an in-depth picture. And we'll be looking at different models of care within the health system, shifting to patients, shifting to community health workers, and then, as I was saying, this use of technology and machines through machine learning and artificial intelligence. So the first one is to think about what I was talking about with new ways in structuring your health professional structure within your hospital. Who's delivering what and in what teams, and between various types of health professional in the structure in which ways are delivered. So what I mean by that is a classic example, a very prominent one, is the multidisciplinary team. And we will look to the evidence on multidisciplinary teams, for example, for lung cancer care. And actually there's quite limited evidence on kind of improved outcomes, which is interesting. And again, this is something that we'll touch on some other slides, but it's also saying that often task shifting can be brought in because it sounds like a good idea or intuitively will work. But actually it's important to step back and say, well, if we are undertaking task shifting, what do we expect the outcomes to be? And actually does that happen? So evaluation is really key. We do see evidence of better care for fracture liaison services, for example, but again, a lack of evidence for things like vascular access teams. And in relation to maternal and child health, again, we have a bit of a mixed picture there. So for example, with HIV care, what we have is some evidence where we actually see a risk of increased deaths when certain tasks are shifted. But actually, for example, no difference is seen when care is initiated by a doctor, but the follow-up care is undertaken by a nurse. So it's the details really matter, and understanding that kind of context and what works and what doesn't. And then thinking about task shifting to patients, and this is a really, really important aspect actually of task shifting, because we know that the role of patients in their care has changed profoundly in the last few decades. And actually we're seeing a real emphasis on patient-centered care, empowerment and development of their skills. And this is absolutely crucial to advancing our health systems and you know, people's autonomy. But what's interesting and what's very, very important actually is that the evidence for improved outcome is limited. So while you may have an increase in quality of life and patient autonomy, but we're not seeing that translated into improved outcomes. And again, that's really about stepping back and having a think about what's not just intuitive or sounds like it should work. What is working, what isn't, and how can we improve what's going on here? And again, we're seeing variable evidence on the role of how to use technology to enhance people's self-care. And that's important because there's lots of technologies out there that do so or claim to do so. So again, we need to understand. So for example, we do see that actually technology enhances people's ability to monitor their oral anticoagulation, for example, but actually the use of pulse oximetry in other conditions doesn't appear to, well, the evidence of benefit is lacking at the moment. And then other considerations are task shifting to other types of health workers. So for example, community health workers, and they've been part of health systems in particularly low and middle income countries for many years now, and particularly in the context of maternal and child health. And we do have some evidence from high income countries, but it's less common and not as well researched. What we do see some evidence of benefit, particularly in relation to particular roles such as psychosocial support, breastfeeding support, but again we have insufficient evidence for other contexts. And another consideration is earlier reviews really emphasise the role of this particular type of healthcare worker in supporting deprived families, or in particularly in the context of underweight or undernourished children. In relation to high income countries, there is some evidence, again, looking into not necessarily the specific outcomes, but actually the role itself of the healthcare worker. And they found that often they're underutilized, unregulated. And again, this is a big issue when it comes to task shifting, is who's regulated to do what. And that's a really important aspect we'll touch on just towards the end of the talk. And then they're often unrecognized. So, and that's a really important part of having a healthcare workforce that feels motivated and supported. And the other is the lack of training and integration. So these are all considerations that are very relevant when we have to trying to optimize the use of task shifting. And again, kind of falling back again on this, questioning of assumptions and intuitiveness, is things like patient navigators. So for example, in high income countries in particular, we're seeing the introduction of patient navigators. Really, they support people through complex care pathways, and that sounds like it could be really a good thing, and I'm sure it could be, but we identified a lack of evidence to draw any solid conclusions about effectiveness or cost effectiveness. And that's really important, because we need to understand how we can enhance that role so it actually leads to benefits, but also that it's cost effective. So drawing all these research together and these findings, and thinking about what the kind of larger picture of the evidence base and what we know is going on in health systems, we actually came up with a series of recommendations within the report. And really these are about kind of asking key specific questions about what you're trying to achieve, who do you need to do it, what do you need to consider, and how we can integrate task shifting so that it's effective and useful, and also actually leads to better patient outcomes. And I'll just touch on a few of these, and then we'll be handing over to Claudia. So it's really just about stepping back and saying, what are we trying to do? What can the tasks be shifted, and should they be shifted? And really being clear about what you're trying to achieve by task shifting, not just doing it for the sake of it, but having a clear goal and then making sure that that does translate into patient benefit, and making this explicit from the outset. Transparency is key. It needs careful preparation. Think about the ability of those people who you're task shifting to, what training is needed, and thinking about those barriers. So for example, the legal barriers, the regulatory barriers, the payment system barriers, and these are going to be profuse in your health system. There are always barriers, and they need to be identified. The other thing is we really advocate for a systems approach. So your health system is intricately intertwined. Every subsystem that you start to fiddle with will have implications on the other parts. And so if you are undertaking task shifting, we need to be really thinking about how it affects the wider system. So if you're expanding the role of nurses, for example, they're taking on more roles, doesn't mean that they then start not meeting other requirements in other parts of the system. So it's really important to be thinking about this kind of wider systems perspective. And what I wanted to portray with this slide is to, what I mean by who is at the table, it's involving those who are actually going to be effective. And we see in health systems all the time these top-down measures that are, kind of given to health systems and healthcare workers and told this is what you're going to do. And what we then find is that the barriers haven't been identified because those affected haven't been involved. How things are actually going to be done haven't been considered. And like a lot of things, when you don't involve those affected, they just find ways around it or find ways of changing it so they can revert back to their old ways. And that's a really important consideration. And the other is governance. And again, what we do often see is the implementation of new initiatives like task shifting into healthcare systems, but it lacks governance. And what I mean by that is it lacks transparency, it lacks accountability. Who's going to evaluate it? Who's going to make sure things go right and not go wrong? Who's going to be involved when something does go wrong? And you know, it's a foundation of a successful initiative is this kind of backing in considerations about how to make sure everything runs well. And really just to kind of stress, coming back to looking at this research as a wider body of literature, is to say, while we have, you know, it is a very large body of evidence and there's a lot that can be learned from it. But what we did notice is, as I was stressing, is it's very varied. It's often ad hoc. It's often performed after the initiative has already been implemented. So, you know, the evaluation plan and thinking about how you're going to actually test the outcomes hasn't really been designed from the outset. Importantly, we found almost no evidence of any consideration of outcomes in relation to equity. And considering, for example, that we're looking at the health system, there was no consideration of equity in health outcomes or access. And that's a really big gap in the literature. And of course, as I was saying, there's going to be a real wave of literature on task shifting after COVID, and thinking about how that could be done really well so that we actually end up with a good body of research based on the pandemic and what happened. And so I'd just like to leave you there, and with just references back to the report. And as Martin said, it is freely available through the expert panel website. And this is just a reference back to the initial framework that we built upon for our work. And so now I'll go back to Dimitra, and I'm very happy to answer a lot of questions as we go back through the question panel.
Thank you very much indeed, May. And once again, you get the prize for the most amazingly designed PowerPoint slides and inspiration to us all. So what I'm going to do now is we will take, I see there are some questions and questions coming in from the audience. That's great, but we're going to save them for the end. And I'm now going to move on rapidly to our next presenter, Claudia, who is going to be developing what May has been talking about and focusing in particular on the role of the nurse and implementing task shifting within that context. Claudia, over to you.
Yes, hello. Good afternoon. It's very nice to meet you all virtually. I'm here now about to upload the presentation, so if you give me a moment. Yes, here we are. Yes, as I said before, my name is Claudia Maier. I'm a senior researcher with the Technische University in Berlin. And I'm also a research fellow with the European Observatory on Health Systems and Policies. And I've been conducting research on the health workforce, on skill mix, on migration of health professionals over the last 10 or 15 years or so for quite some time already. And yes, it's a pleasure to be here and share findings from a study that has been ongoing for 2 years now almost, with the European Observatory on skill mix. So yes, so what I will address in this presentation is, first of all, what do we know about nurses in advanced roles and what is the status quo in Europe? And I will give you quite a number of country examples and experiences where I will share with you. And second, on implementation, we will look a little bit more in detail on what is the role of regulation and legislation, of course, and what do we know about payment policies and implementation. And I think this fits pretty nicely with what May already presented, because she focused very much on the evidence and on outcomes. And my presentation will give you more insights into the whole implementation process. So as I mentioned, so this presentation is based on two major studies. One is an OECD report on nurses in advanced roles that I did in 2017 together with Linda Aiken and Reinhard Busse. And the other one is an observatory study that we are about to finish, and it will be published very soon, on skill mix innovations, where we looked at effectiveness and implementation. And I will present you the findings on the implementation side, because as I mentioned, May already talked about the elements on effectiveness. So first of all, when looking at what is the status quo in Europe on task shifting between doctors and nurses, what we did was we did a study, a survey in 39 countries in Europe, plus 4 countries outside Europe. This is the United States of America, Canada, New Zealand, Australia, other countries outside Europe, and within Europe, all 28 member states, plus Norway, Switzerland, Iceland, and Turkey. And what we did was, as I mentioned before, we did a survey to 93 country experts, where we asked them about all sorts of questions related to task shifting. So for instance, are nurses with certain specializations or qualifications, are they authorized to perform certain tasks, such as prescribing of medications? Can they treat patients and make decisions on treatment, for instance? Can they order diagnostic tests? Can they refer patients to other healthcare providers? So these are all tasks you see that go very much into the remit of the medical profession. And these are, when we talk about task shifting, these are typical tasks that are being considered if they should remain within the authority of a physician, or if nurses should be allowed to also perform some of these tasks. So we asked these experts if nurses are officially authorized to perform some of these tasks or all of these tasks in their country context. And you will see later on, it's a very mixed picture across Europe. And then the analysis was based on a quality, and we asked all sorts of other questions, but I'm not going to go into detail. So it was also on implementation, the role of regulation, payment policies, and so on. And the analysis was based on a qualitative and policy analysis, where we looked at the reforms on task shifting in these 39 countries, on legislation, on the role of regulation, and payment policies in particular. And before I share with you the findings, I think it's very important to know that when we talk about nurses, most countries have very different groups of nurses that are all called, of course, the umbrella term is a nurse, but then they are very different types of nurses in terms of specialization. So we have, in all countries, we have the professional nurse or the regulated, it's also called a registered nurse, which is in Europe, we have a minimum harmonization. So there are some minimum standards that apply. So that is the professional or registered nurse. But then most countries in Europe and in other countries worldwide, they also have all sorts of specializations. And it's always important to bear in mind what kind of education do these nurses have. And I would like to highlight 2 groups of nurses when looking into task shifting that are important. So first of all, here you can see it's called NP/APN. So this stands for, NP stands for nurse practitioner, APN for advanced practice nurse. These are nurses that have been educated to usually the master's level. So the education is pretty advanced, pretty high. And they have, according to the International Council of Nurses, acquired an expert knowledge base. So they have an expert knowledge and skills and clinical competencies for expanded practice. And this expanded practice very often is also referred to as task shifting. And as I said, the master's degree is important. And then there is a very diverse group of other nurses who also work in somewhat advanced or extended roles. And these are often nurses. They are called nurse specialists. They have some additional training. They have all sorts of, you know, oncology nurse, lung nurse. They got also additional training in addition to the registered nurse. And they also work in advanced roles, but not at the extent as is done for nurse practitioners or advanced practice nurses. And when you look into specific countries, very often it's even much more complicated than this. So this is still a simplification, but I think it's important to bear in mind at least that distinction between nurse practitioners, advanced practice nurses, and other nurses with some sort of additional qualification. Yes, and so what is very important is to look at, when we do international research, to look at the titles, what are they called, what is their scope of practice, and by scope of practice, we mean what are they officially in a country authorized or allowed to do in practice, and what is their education. So here we see some of the findings of the research. So there's a group of countries where there are this nurse practitioner, advanced practice nurses. They have been established for some time already. They have advanced levels of clinical practice, so the scope of practice is pretty advanced. And this means that task shifting has occurred in the past in their country, so their scope of practice is enlarged. And the countries where we found that this is the case are, you can see them yourself, Australia, Canada, New Zealand, United States, outside Europe, and that was the hypothesis beforehand. We knew that they have a long tradition of nurses working in advanced roles. And within Europe, Finland, Ireland, the Netherlands, and the UK. And why this group of countries grouped together? Because as I said before, they have the role of nurse practitioner, advanced practice nurses established for some time. Education exists at master level at universities for some time. So there is a group of nurses that are now routinely educated to that level, and their scope of practice is pretty advanced. And here you can see on the slides, they are officially authorized to perform all of the following activities. So they are authorized to prescribe certain medications. They can order and do certain diagnostics and diagnosis or advanced health assessments. They can order certain tests and exams. They can make treatment decisions. They have a panel of patients for whom they are responsible. They can refer patients to other providers or to hospitals or clinics, and they can be first point of contact in primary care. And then there's a group of other countries where this is a new development. It's task shifting is currently something that is debated, that is ongoing, where there are a lot of discussions, debates, sometimes battles happening in these countries, where there is discussion of what should be the scope of practice of these nurses. And that group of countries, that is what we have called emerging in these countries. So these are countries that have so-called nurse practitioners, advanced practice nursing education programs established. Some of them is still very recent, but the practice is at the moment not that advanced as compared to the other countries I just showed to you. And here you see it's a large number of countries in Europe where currently this development is happening. As I mentioned, education is emerging at the master's level, and scope of practice, there is some task shifting happening, or it's being debated, but it's not as established than in the other countries. So here you can see these are the two country groups. The first country group that I mentioned is where it is already implemented for some time. What makes it also interesting, this group, is that the nurses, they can actually cover nearly or a full patient visit. So this means from the first point of contact, they can be the person that the patient sees. They can do the diagnostics, they can make some decisions on treatment, make follow-up. So here there is some clear division of work, at least in theory. In practice, sometimes, of course, there are some issues related to that as well. But in theory, they can take care of a patient in a holistic way. And in the other countries, as I said, it is emerging. So I would like to also give you now examples of what is happening in countries. On one example of task shifting, and May already also mentioned that in her presentation. This is one task or clinical activity, which is currently very heavily debated in Europe, also in the literature. There's a lot that has been published. It's prescribing of medication. Prescribing of medication in many countries was for a long time, or is still only the remit of medical doctors. And this is now changing. So it's also called non-medical prescribing. And a lot of countries are moving into this direction and say, okay, we are reconsidering if other non-medical professions should prescribe certain medications. And here I give you the example of prescribing rights given to nurses in a number of countries. And here you can see that just over the last 10 years, now we have 1 decade since 2010, a total of 8 countries within Europe have actually adopted new laws to grant nurses certain prescribing rights. You can see them themselves. So this is a big innovation for these countries, because the nurses were not allowed to prescribe medications before these laws, and now these laws have been enacted, and the countries are trying to find ways to implement that in a smooth manner. And it's not always that easy. And then there are other countries, you can see them also here, many of them outside Europe, but also some within Europe where nurse prescribing existed before 2010. But, and you will see that in a moment, they expanded, a lot of the countries expanded the laws and allowed nurses even more prescribing rights. So here in the first group of countries, you see prescribing rights is new for the nurses, and very often there are limitations to the medications that nurses are allowed to prescribe. It's very often medications for common chronic conditions or minor acute conditions. One example is the Netherlands, where nurse specialists have been granted much broader prescribing rights from the beginning. And then in the group of countries that I mentioned before, where nurse prescribing pre-existed, these prescribing rights were expanded and to a much larger number of medications. So I would like now to give you one example of what does it mean in a country? What happened, you know, in a country? I chose Finland. I've been to Finland 2 years ago to study there. They had a new law on nurse prescribing, to study that in more detail, and I visited also a number of care providers and care settings. So I went to a primary healthcare clinic, I went to a hospital to understand and to talk to the people working there. What does it mean if there's a new law that has been implemented? And I will share with you in a moment an example from a hospital in Finland of what it meant to actually implement such a policy in their hospital. So just for you to have some background, so in Finland, since 2010, there is a new law that actually grants nurses some prescribing rights. It's regulated, so this means the nurses have to undergo an additional training at the postgraduate level. That was also regulated in 2011, and they have to take that course on prescribing. It's a number of different classes and courses on pharmacology, pharmacotherapy, health assessments and so on. It's 45 ECTS, so this is equivalent to almost a year of full-time study. It's 3/4 of a year. And what they have to pass an exam at the end. And then after they get the title of, it's called nurse prescriber, they can actually prescribe certain medications. And here there was a differentiation in the law. So initial prescriptions, they can prescribe for local anesthesia, medicines for pharyngitis, contraceptives, and a few others. So it's very limited number of medications where they can do the initial prescribing, and then continued prescribing, which means that after a physician has done has written the first receipt, and then they can do the follow-up prescribing that they can do for certain chronic conditions, which are for hypertension, diabetes, and asthma. And the requirements for these nurses in order to be allowed to prescribe medications is they need to be employed with the municipal health center or hospital by the municipality. They need 3-year prior work experience. As I mentioned, the education, additional education, they need to be authorized by a physician in order to prescribe medications. They need to be registered as a prescriber, and they need an identification number with a regulatory body. And I mean, as you see, it's pretty heavily regulated. There was a lot of movement back and forth. There were pilot projects beforehand which showed actually overall very good results with that. And so there was a lot of development before that law was enacted, but then in 2010 it got enacted. And so what does this mean now for working in practice? As I mentioned, I went to a hospital in Jyväskylä in the mid, I'm sure it's wrongly pronounced. It's in the middle of Finland, and there's a hospital responsible for quite a large catchment zone. And in that hospital, the emergency department, I show you that was the traditional division of work in that ED room. So of course they had a triage system, and patients were classified by urgency. There were A, B, so-called AB patients, where treatment had to be done within 10 minutes. So these were the real emergency cases. Then there were CD patients called C and D, where treatment had to be started within an hour, and the so-called E patients, where treatment was actually assessed as not necessary to be performed in the ED room, and there was a referral to ambulatory care. And prior to the law that was enacted on nurse prescribing, treatment was done by physicians for all of these patients, and of course their teams, the other healthcare providers working with the physicians in the ED. After the law was implemented in 2010, and another reason for the hospital to restructure the ED was that they had faced issues in recruiting sufficient physicians into the emergency department. And the chief medical doctor was open to having a new group of nurses with expanded clinical skills and competencies. And what happened then, what they did was they actually restructured the patient flows in a way, oh, I have to go back, in the way that, again, patients by urgency, the A and B patients within 10 minutes were, of course, treated by physicians and the team. But for patients where treatment had to be started within 1 hour, there was a group of patients where it was decided that nurse prescribers would take care of these patients. So for instance, patients with small fractures, with the wounds or burns, with urinary tract infections, with eye infections, they were handled by these nurse prescribers. and patients with the other conditions were again handled by physicians. And I talked to the nurse prescribers, but also to physicians, and asked them, how does it work? Does it work well? How is it organized? And they said after an initial period, of course, of reorganization and some sort of issues with clarity, who does what, and so on, it actually now works pretty well. The nurse prescribers, they have their own treatment rooms where they get, the triage nurse allocates the patients to the different rooms, and the nurse prescribers can handle certain patients themselves. The nurses told me also that if they are not clear, if it falls within their competency, or if they see any complications or issues, they can always ask the physician. And one of the results of what they found was that they can now they can be faster in treating the patients, so the access has improved. Overall patient satisfaction is also improved or the same. But I must say this is based on what these providers told me. So it's not based on an evaluation or any sort of formal assessment. So going back from this one example in Finland, of course, the question in this presentation is about implementation. So when a country decides, or let's say policymakers say, okay, we want to do something, we want to enlarge the scope of practice of nurses, for instance, of course, the question is what can be done at the policy level. And we looked into the issue of the role of regulation in the implementation process. And regulation of, so health professionals are usually pretty heavily regulated. I mean, I'm sure you all know that the titles of physicians are all regulated across most high-income countries, or all high-income countries. Of nurses also, titles are regulated. The scope of practice is also very often regulated by law or bylaws. And by that I mean that it is regulated by law what physicians are allowed to perform. And there are certain tasks that in many countries are called reserved to one profession only. For instance, prescribing of medication, as I mentioned, is often reserved only to physicians. And there need to be changes to the law that other professions can actually perform this task. So that's why it's very important to look into the laws and the regulation when considering implementing task shifting. Because if a profession is not authorized to perform a certain clinical task in practice, they are working unofficially in these roles, and it has all sorts of liability issues afterwards. So there is no way to implement task shifting if there are no changes to the law, if these tasks are regulated. And we know all that countries have centralized and decentralized systems in their governance. So in countries where regulation is at the national level, here you can see locus of regulation at the national level, if scope of practice is regulated, it can be a restriction to implementing task shifting if the task is only very restrictively regulated to one profession only, and that's mostly the medical profession. And this is often slow to change. So as I mentioned, in the case of Finland, but also in other countries, sometimes it took 5 years to change the law, sometimes it took 10 years to change the law. In a few countries, I think it was faster, but generally changes to the law are very time consuming. If regulation is at the sub-national level, then it applies, it's often regulated at the state or province level. And there, very often, there is an uneven development. And the speed is also quite different. For instance, the United States, There have been efforts ongoing to change scope of practice laws in the different states now, I think, for almost 30 or 40 years. And it's a very uneven development. And it means that nurses have different authorities in what they can do in clinical practice, depending on the state in they work. So here you can see a number of examples, policy examples, what countries have actually done to change the situation. So in the Netherlands, there was a change to the scope of practice in 2011 for nurses and also for physician assistants. And this actually came, in the beginning, there was a group of independent experts who reviewed an existing law, and they said actually that certain tasks and procedures are only reserved to the medical profession. They said this is kind of outdated and should be revisited. If there are not other professions who should also be entitled to perform these tasks. So I think this was one of the triggers to actually, for policymakers to think about if there should be changes to the law. And then there followed a whole debate about what tasks should be shifted and so on in the Dutch context. Other examples are so-called experimental clauses or pilots that are embedded in a law to allow countries to pilot changes to scope of practice for certain professions. Here they are, again, we have the example from the Netherlands where this happened, and the state of California in the United States. New Zealand was very interesting. They tried to implement a so-called omnibus bill, which means that they said we want to not make changes in one law after the other, but we want to make changes in all laws where it's applicable altogether. It took a very long time, it took 10 years, but finally they made it with that policy approach. And Finland is a country where there was a stepwise implementation, where there were first pretty rigorous pilots of task shifting. This was discussed with stakeholders and then later implemented as a law. Yes, and at subnational level, there are some countries that actually they have been moving to harmonize legal requirements, and there have been also different approaches to that. I'm now skipping this in terms of time. Role of payment policies and reimbursement. So that's another element to look into. And it's very important to bear in mind that reimbursement and payment policies are very important factors when considering implementing new roles for nurses and other healthcare providers. So in fee-for-service systems, the first question is, are the providers being reimbursed for these new tasks? And what is the level of reimbursement? And for instance, in Australia, there was the case that prior to 2010, nurse practitioners, they were allowed to prescribe certain medications, but the patients would not get reimbursed for these medications because it was written by a nurse practitioner and not by a physician. So the nurse practitioners, they told me that they told the patients, I could write you a recipe, but you will not get it reimbursed. So it's better to get it from the physician. And then it was realized that this was a major barrier to task shifting in clinical practice. And so the law changed in 2010 on that. In the United States also, there are a number of examples where payment and reimbursement schemes have been barriers to the practice of nurses in advanced roles. In countries where nurses have usually salaried positions, one of the barriers is a lack of funding for these new positions, and that has been reported in Canada, Finland, and the Netherlands, where there had been issues about if they can fund such a new position in hospitals or in primary healthcare centers, and where the funding should come from. Should it come from the nursing budget or from the physician, the medical budget? There have been all sorts of issues around that as well. And then one of the policy instruments to actually speed up implementation is the role of financial incentives, where there have been examples from 2 Baltic countries and from Finland, where they used financial incentives to actually kickstart and speed up the implementation of nurses in expanded roles. And that worked pretty well in these countries, with some reservations in the beginning, I would say. Yes, this is an example I will skip. So coming to the conclusions. So implementing task shifting, it's pretty complex. I hope I was able to convey that message. It requires very often changes to legislation. The role of payment and reimbursement policies is important to look into. And of course, one needs a sufficient education pipeline to have the nurses educated to the levels of what they should be doing in their clinical work. Critical factors that we found was that to make such a change at the national level, so for the entire country, there needs to be support from the Ministry of Health. There should be a system-wide approach to it, including education and workforce planning. Evaluations are critical, involving stakeholders early on in the process as well, and the use of incentives to kickstart implementation. Thank you very much.
Great, thank you very much, Claudia. And with that, now we move on to the Q&A. And I'm going to ask Dimi if she can take us through some of the questions that have been high on the list of what people have been asking.
Yes. Thank you very much, Martin. And thank you everyone for your very interesting questions, for some of your answers to other participants' questions, and also for reacting to the questions that we have ranked more or less list now. I think the first question, Claudia, that I would like to pick out is also the most highly ranked question. I think Claudia briefly addressed it in the Finnish example, but the question is if there is research and what does it tell us about whether the health professions themselves actually are happy with task shifting. Do nurses actually welcome taking on new tasks, and are doctors really happy to pass on their tasks to nurses? Perhaps some short reactions on that.
That's a very good question, and we looked into that as well when we did the research. There is actually not that much evidence out there on what the health professionals think themselves. There are some, and not very systematic, but there are some country case studies or some examples. For instance, I remember one example in Ontario in Canada, where there were in rural practices, where there were physicians hiring nurse practitioners. And what they did, they worked in their daily job, as we would expect, I would say. But what they did as well, they reached out to the community and tried to improve access for those patients that were vulnerable, that would otherwise go too late to the doctor. So they were very engaging in their practice, and they surveyed afterwards the physicians and the nurse practitioners themselves, and the physicians were actually more happy since they had the nurse practitioner on board, because they said they could focus more on the more complex patients, they had a little bit more time for the patients, and they appreciated that the nurses did these outreach activities to the community. But that is one example. I know of other examples that also sometimes in the beginning when implementing change, there's quite some confusion. There are sometimes nurses who say it's too much and so on. The physicians, they very often have reservations that there will be issues in terms of patient safety. But after the transitional period, usually what I have seen is that where the evidence exists that the providers are actually pretty happy in their job.
I might jump in on that if I may, and maybe May might want to comment as well. I think what I've been struck by in a lot of work is that a lot of it is to do with payment systems. There is a saying by an American writer, Upton Sinclair, it's very difficult to get someone to understand something when their income depends on them not understanding it. And when we produced our report on vaccinations in the expert panel, we were very clear that you do not need to be a physician to give a vaccine. In fact, frankly, as a physician myself, it is a complete waste of your time to be doing that. And in many countries, pharmacists give vaccines, nurses give vaccines, other people give vaccines. And yet we found that, for example, the German Medical Association was very strongly of the view that this was impossible and dangerous and so on, even though it's done everywhere else. So I think the payment system is critically important here. But also with that, we need to make sure that if people take on other roles, they are supported, they're given adequate training. May made this point very well as well, and they're adequately rewarded for doing it. People want to do interesting work. They don't want to just fill their time, and that's what being in a profession is all about. So I think often we're pushing at an open door with this. People will support it, providing they are supported themselves.
I think I might just add to that. Martin, was you're quite right in that, you know, one thing you said was having the right support, and I think we also, I think there's an issue here with the researchers as well. Just coming back to what I was talking about broadening the research questions and the quality, is that there is very little qualitative work in this area as well. And so asking people, exactly as this good question is highlighting, is are people engaged in it, and are they willing to take part? Something else I was mentioning is if you're not transparent, you don't have a clear goal, you're unlikely to get buy-in. But the other thing is to also, I think the training element is a huge factor there. So as well, if people won't do it, if they don't, we found in one study in particular that if people didn't feel supported or capable of taking on new tasks, then obviously that's where you'll get the breakdown. And I think the other thing, just echoing with what Martin was saying about payment systems, but also something I mentioned briefly is challenging those kind of underlying assumptions and hierarchies. There'll be a lot of, but we've always done it this way. And if people feel that their position is potentially being threatened as well, so if the person if you're taking a task away from a particular group, there'll also be, you know, there's maybe a fear that then what else will be taken as well.
And I think very fitting here is another cluster of questions which has to do with the role of the patient and the perception of the patients. And probably for the patients is also not as straightforward when there's a major change about who is the one who is prescribing their medication, or who is the one who's administering the vaccine. So one of the questions has to do about how patients accept that. And the other thing has to do with the shifting to patients, and whether that is possible without adequate patient training, and whether COVID, for example, can provide one example for us with the increase in e-health services, where the patients, and some of the patients who might not have been comfortable using telemedicine before, did not have a choice but had to use telemedicine now. So the perspective of the patient in all of this is also quite loudly heard among the questions in the group. So perhaps your reactions to that area.
Who would you like to comment? I can, but I'm happy to let the others.
I think I leave that up to you, Martin, to decide.
Well, I'll maybe just jump in briefly and say, I think things are changing dramatically. Look at our own lives. We're now, many of us, spending 8-10 hours a day on Zoom in a way that we never would have thought possible. Now, there may be consequences for our sanity in the long term. Maybe I'm already going mad. But I think and also we're going to see a generational issue here. We're going to see, as we move forward, a lot of people have made that shift to doing lots of things online that they wouldn't have done before. And I think many of them will continue to do that. We need to be very careful about the digital divide. We need to recognize that a lot of people in rural areas may not have high-speed broadband and so on and so forth. And the same principle applies as with shifting, task shifting to different health workers. You have to support people. You can't just say, you're on your own. If this is seen as a way of just telling patients, you're responsible for looking after yourself and we want nothing more to do with it, that's absolutely not going to work. And it, just in the same way that task shifting from, to take the classic example, doctors to nurses, which is the more commonly used, the more common examples, if that then is not accompanied by empowerment of nurses to make decisions, and a higher status in the relationship, it will not work. So training, support, empowerment matter regardless of where you're shifting the tasks.
Can I just add, in terms of acceptance by the patients of task shifting, it's actually very interesting from the research that it's actually well accepted in those countries where there is a longer tradition of task shifting. I'm not talking about countries that have just started the process, because there are so many changes, and it's important for those countries to have a clear communication strategy also related to that. But the countries with a longer tradition where nurses prescribe medications, the acceptance is very high among patients, and patient satisfaction overall from the research that we have shows actually at least equal or very often higher patient satisfaction rates. And we looked into why the patient satisfaction rates may actually be higher. And what we found that, again, it's not 100% clear from the evidence, but one of the issues with task shifting often is also that when the task is being shifted, very often the new provider takes more time for that task. So that is, for instance, shown for the nurses. On average, sometimes it's even double, so there is a range, but they take a longer time with the patients. And it's not entirely clear why they take longer, the nurses. There are some hypotheses related to that. So some say that the nurses, they provide more communication, more information to the patients when they, for instance, prescribe medications, and more education. And that could be a hint why potentially patient satisfaction may be higher. But again, it's something that needs to be further explored. Another possibility could be that the nurses are not as efficient as doctors, so they just take longer. They don't have sufficient support from healthcare assistants or others. So there are different elements that could explain the difference. But what we know is that generally patients are actually pretty happy and satisfied.
Okay, and perhaps since we already touched on technology here, another cluster of questions and reactions have to do with shifting to technology and new roles that have to do with the new technologies, like interface for different algorithms or apps. And also the title of the session was the right person or machine for the job. So is there a space here for increasing the contribution of technological advances and innovation to maybe require different types or less task shifting between professions?
Can I go on that one, Dimitri? I must apologize because we missed that slide in my talk. So I will, if I can, I will share and go through that slide, because I realize we actually skipped right over that, and I can maybe go through it, and then if there's other things that we don't answer the question, if that's okay. So if I share my slide. Okay, so my apologies again, because we did just skip over this. So I'll go through there, and if there are any other questions, we can go into it. But it was, so we looked at a lot of different aspects actually of shifting to what we call machines or different technologies or artificial intelligence. And actually, this is really important, because and a really important question, because we're seeing this in our entire lives as we've been talking. We're on Zoom all day, and every other sector is moving. So if we just start with health apps, for example, what we actually saw there, which is important, is that actually there's very little evidence, surprisingly little, given the absolute inundation we have with health apps, and actually many go unevaluated, which is an important consideration, but also the fact that those evaluations that are undertaken can actually be quite, there are concerning aspects to them, and particularly in relation to conflicts of interest. And what I mean by that is A lot of these evaluations are commissioned by the very same people who write or sell or potentially profit from these types of applications. And then there's the whole eye wearables or tracking devices. So a big one being the Apple iWatch, and there's big trials going on at the moment. And again, here it's very mixed picture. So, you know, all the things we wear around our wrists and all the health apps and the way they track our data. And again, there are some other major considerations here. So the ethical and the governance issues, as we were talking about. So who owns this data? Actually, who is ultimately the ones who are going to benefit? Is it publicly owned data? Does it make profit? And who gets to decide all this? There's some really big issues. And then there's the use of artificial intelligence, and something that I think is really important here is to think about the balance. So a big part of our report was looking at this, and here we've got things called like terms arising, and what I've captured here is the iatrogenesis. So exactly like iatrogenesis, but harm through the introduction of health information technology. So for example, we see the use of artificial intelligence in starting to read scans. And again, a kind of way of thinking about where you might get harm versus benefit is artificial intelligence going to be used to enhance the role of health professionals, or is it going to be used to replace? And then if it is replaced, how do we make that safe? Or if it is enhanced, does it enhance or does it undermine? What do you do if the artificial intelligence comes up with a different answer to the physician, for example? And then also the kind of wider considerations here in relation to that is, so there's kind of security issues like cyber attacks, but then also who's writing the algorithms. So are the algorithms written, and we have seen evidence of this, that they're more likely to suggest further interventions for a patient, which ultimately does lead to someone profiting. So there's the kind of nitty-gritty of does the technology work, but there's much bigger issues around ethics, who benefits and who doesn't. So hopefully that's a way of starting to answer these questions. And apologies again for missing that critical side, but thank you for the good question, which allowed me to answer it. You can go back to it. That's great.
Either Martin or Claudia want to jump in, or shall we don't, I'm looking at the time, we have 5 minutes, maybe just take some more questions?
Well, just to say, as May said, it's really a big issue, actually. And it is, I think we all have to realize that there are a lot of these things that are being promoted by people that have never been evaluated. So we need to be very, very skeptical when someone is trying to sell you something and they can't show that it actually brings about a benefit. That said, obviously, it is much better to have data from some sort of a wearable device that will, for example, tell you what your blood pressure is continually over a 24-hour period, rather than going to a doctor and having it measured once, or having your blood glucose checked over a 24-hour period, rather than just taking a blood sample once. So clearly there are many theoretical benefits from all of this, but the big issue, as May was saying, the algorithms. We need to be very clear as to who the algorithms are developed on. There are many examples of algorithms that have been developed in one ethnic group or one national, one group, one gender, often on men, and not validated on women, for example, as we've seen, for example, with criteria for diagnosing myocardial infarction in the past. So we need to be sure that the algorithms actually apply to everybody that is using them. And obviously, in a world where we have I mean, I'm speaking from the United Kingdom, and we had the scandal of data being harvested in the Brexit referendum. We need to be very, very careful about how the data are used. And unfortunately, in this country and in the United States, there's a serious lack of trust. Unfortunately, this is a tragedy for healthcare, but that lies firmly, that clearly is the responsibility of some politicians for having engaged in outrageous behavior and undermining trust.
Thank you, Martin. I'm in a little bit of a difficult situation here, because there are many interesting questions still, and we only have 3 minutes. So I'm going to try and give the 2 main areas that are reflected in the questions that I see we still haven't answered, and maybe we can just go for some quick reactions to those. The one, it has to do with the fact that given the competencies of advanced practice nurses, it would probably be necessary to restrict to certain areas of nursing care, like having, say, orthopedic nurses. And then if we have a general lack of nursing staff, who will then be performing the more general nursing tasks? So that's, I think, the balance between the workforce as a whole, and then how the task shifting develops it in a certain direction. That's one. And the other one is more about other professions next to nurses. So we have two questions. One is about physiotherapists. The other one is about social workers. And perhaps now with COVID and with people reaching out at the homes of the patient, what do we know so far about these professions, and what can we maybe think about to address the new situation that we have?
Okay, on the nurses, this is a question that is being raised pretty frequently when I present on the issue. And of course, we have a nursing shortage in several countries, or many countries, even in Europe. There are two issues to think about when discussing task shifting issues. First of all, education of nurses has been raised to bachelor level in most countries, either entirely or partly. And this is being followed by master level programs. So the educational pipeline goes directly into a more advanced level, which also very often is complemented by the training of nurses in advanced clinical skills. So they have the skills available, they have the skill set. And then to say as a country we don't use the skill set is a loss of skills, which of course a country needs to decide themselves if they want to go into that direction or not. So education goes into that direction. In countries where there has been task shifting implemented for some time, there has also been task shifting between these advanced nurses, advanced practice nurses, and the professional nurses and the nursing assistants. So one needs to see the nursing profession within these different subgroups of nurses. And there needs to be, of course, also some sort of a strategic approach of who does what within the nursing workforce. There is a risk that those countries with bachelor level nurses, for instance, in Germany, we have that at the moment, the bachelor nurses, very often they work a couple of years in hospitals or somewhere else in Germany, and then they are frustrated because they cannot use all their competencies and skills. They want to do a master, and either they do a master in nursing, and then they have a more enlarged scope, or they go out of the profession altogether. So there might also be a loss related to that. And I think from a policy perspective, what is very important is to keep the nursing workforce motivated and use their skills to the effect possible. But of course, it is a change in the skills of the nursing workforce, and that needs to be, as Martin said, supported by all sorts of supportive factors, payment, work environment, and so on. I stop now.
Thank you. May, Martin.
Oh, I've nothing to add in light of time.
Just really quickly, I think kind of along with this question is that task shifting is obviously very specific about maybe a task or a different role changing, but it's also about building an ethos of flexibility as well. So, you know, as we saw, it's about saying, as the question was highlighting, that you might have a very specialized group that does something, a task very well. But it's about saying, okay, but when the need changes, and we saw that in COVID, how do you take that skill and move it to ICU or another part of the health system? So it's about this specifics, but also about that kind of wider culture of, if you've got this type of task, how do you then change it to another role quite quickly?
Okay, thank you very much. I think I will wrap up the Q&A and pass on to Martin just briefly by saying, there are a number of questions that we haven't had the time to answer. I think probably I expect that it's okay for participants to reach out to the presenters for additional information on the issues like quality control that we didn't get to talk about, or even this idea of the other professions beyond nurses like social workers and physiotherapists, and to ask for evidence that is available. Again, a big thank you to everyone for reacting, and also for the participants who answered each other. Please, of course, feel free to connect outside this room and discuss, because I think it looks like a really interesting discussion moving forward. I was asked by the administrators to remind everyone to fill out the evaluation form that you will see at the end, but I won't go into that in detail. Do that, please. Back to Martin for closing the session.
Well, thank you very much, Dimi, for your excellent facilitation. Just a reminder that the next webinars are on Monday at 11 to 12:30 CET, the Veneto Health System, Response to COVID-19 Strategies, Innovations and Lessons. And then in the afternoon at 1600 CET, Hospitals in the Time of COVID, the Role of the Hospital in the Healthcare System. And with that, I would just like to thank you again, Dimi, to thank Annalisa and the team in Venice and the other colleagues for helping to organize this, and in particular to both of our presenters, May and to Claudia, for some two absolutely fascinating presentations. Thank you all very much and have a very nice evening.